evening. Thank you all for coming. It's really great to see lots of familiar faces. So we'll start because then that means that we can all get home to our families. Tonight I'm talking about 6 nerve palsies, and I'll cover some neuroanatomy because that's quite useful to have a refresher on so that you can have an understanding of trying to understand where the lesion might be. And the key thing for you all is the clinical presentation, just having that down succinctly, because that'll give you confidence as to know which ones you need to refer and which ones you can keep looking after. And I'll go through some cases and we'll talk a little bit about investigations. So why do we need to know about 6 nerve palsies? Well, it's the most common oculomotor paralysis in adults and second in children after the 4th nerve. And the incidence is 2.5 in 100,000. You'll be familiar that the other name for the 6th nerve is the abducens nerve, and you'll also be familiar that it controls the lateral rectus. And it's quite interesting to know that it has the longest subarachnoid course of all the cranial nerves, which also has some clinical implications. There are 12 cranial nerves, and number 6, as you can see, the abducens, departs from the pons, not named after me. And there it is. And I'll show the slide right throughout the talk just because it just demonstrates the whole route where it starts in the pons and then moves, exit through the base of the pons, up through the subarachnoid space, up past the base of the skull, into the cavernous sinus, and then into the orbit. And naturally, all the associated structures will give us clues as to where the lesion might be. There are many causes of a 6 nerve palsy, depending on whether you're in the pediatric age group or whether you're an adult. Some of these are quite serious conditions, tumours, trauma, the list is there. The most common in adults is microvascular ischemia, but the challenge for us is to differentiate which of those are microvascular and which of those are due to a serious underlying cause. So just to make sure that we all stay engaged, because it's probably been a busy day, I'll invite you to think about the answers to these questions, and you might choose to be brave enough and put your hand up and volunteer, or have a discussion with your colleagues next to you, or maybe you want to think quietly to yourself what the answers are to the quiz, and that's mainly the first part of the questions. And I think it's quite good just for you to kind of engage and formulate in your own mind, because these are the bits that I really want you to take away. So what symptoms do patients present with? And how does the onset of those symptoms and the progression help to determine the cause? So I'll just give you maybe 15 seconds to think about that. Anybody feeling brave enough that they might want to voluntear?
Is the tropia worse in one direction? Or?
Super. Which direction?
To the outside of whichever lateral rectus.
Yeah. Okay.
But, yeah.
Great. And in terms of onset, how does that help?
Sudden, like a microvascular event.
Great.
Quick.
Yes, very much so. Yeah.
Maybe.
So sudden is microvascular. Tumours might be...
Both? Sudden or slow?
Yeah, it'll be more... Well, there'll be progression, wouldn't there? And that might suggest... So let's take us to the next slide. So horizontal diplopia, that's what patients will present with. And as you said, the sudden onset reflects the vascular occlusion, whereas a slowly progressive but progressively deteriorating might suggest that there's a compression, an expanding lesion. And a subacute kind of presentation might be suggestive of something inflammatory like demyelination. So now the quiz question, and the question's been partly answered, but describe the horizontal diplopia in more detail, and what other symptoms might the patient have that can help. So one thing that's really valuable to know is that it is an esotropia, or the double vision symptoms will be worse far away. And your patients will say, I'm driving or I'm watching TV and I have double vision, but I'm fine with reading. It's definitely worse, as you said, looking in the direction of the palsied muscle, and naturally better looking the opposite way. And the history, I mean, some of it is pretty obvious. You know, if they've got a history of trauma, they're less likely to turn up to you. GCA might present to you, and you're looking for things like all the cardiovascular risk factors. Do they have any history of malignancy? Do they have any thyroid issues? In children, perhaps they've got an ear infection. And other symptoms, it's not uncommon that people turn up to you with headaches and symptoms of raised intracranial pressure. So the pain around the eyes, their vision, the pulsatile tinnitus, that'll be helpful to know. And naturally any other cranial nerves getting involved. So you might have facial muscle weakness, or they won't volunteer to you about hearing issues, but it's something that's worth asking about, and sensation on their face. So here's another quiz question. What is the main ocular misalignment finding? And what head posture would the patient adopt? Okay, you can see you're all thinking about that. So I'm pretty sure that you're all thinking that naturally there's an esotropia, which reflects the unopposed action of the medial rectus. And to compensate, to avoid that abduction motion, they're turning their head towards the affected side, and that helps to minimize the diplopia. Right, so, hello, come in. So here's somebody with an esotropia, and of the left side, and I'll show you a video clip of him shortly. But here's somebody with a compensatory head posture, and a subtle face turn to the left side. So the next quiz, what would you expect to find on ocular motility assessment? And how does the esotropia differ depending on the direction of gaze, which will pretty much go along with the symptoms, and depending on which eye is fixating, and whose law? I should have brought chocolate fish. Back to your physiology days. Well, I tell you what, let's have a look at a video clip together. And here's somebody that I actually saw when I was in Melbourne. Let's have a look. So he's having a alternating cover. So here's interesting because he does change which eye he chooses to fixate with. So no issues with right gaze, but with left gaze he has limitation of abduction. So limitation of abduction of the left eye. No issues with the right side. Okay, so the key thing about the esotropia is that it's concomitant. It's going to be much worse looking in the direction of the palsied muscle. And you'll also notice abduction deficit, which is asymmetrical. And we usually grade them, mild being -1, -4 means you can't even move your eye past the midline, because it can be complete or partial. But the other thing about the clinical features of a new onset sixth nerve palsy is this idea of secondary deviation, which is such a key finding, because The people that have decompensating esotropia or age-related distance esotropia or accommodative esotropia, they're not going to have secondary deviation. So you're all familiar with secondary deviation? Let me go back. So if you notice the amount of esotropia that he has with his left eye and compare it to the amount of esotropia that he has with his right eye. So I'll play the video clip for you. So there's a small movement there, and there's a large movement there. Can you see the big difference? So that's the primary deviation, and that's the secondary deviation. Right. So I'll move on to the next slide. And who's brave enough to recall their physiology? Whose law is it? No? Herring's. All right. So Herring's is really controlling conjugate gaze, making sure that you have an equal signal going to both the lateral rectus and the corresponding medial rectus so that the gaze is moving together. Okay, so here's another patient who, I apologize for the quality of this video clip. It's pretty challenging trying to hold the camera and do a cover test at the same time. But she also demonstrates secondary deviation there.
So there's a larger movement on the right.
So a small movement
On the left.
and a big movement. Okay, so that's a really useful
Look all the
sign
way
to
to the
look for.
right.
Right gaze, no issues. She's abducting
The kind of
with the right eye nicely, adducting
pedal
with
there.
the left eye perfectly.
Just want you to follow it.
You can see with the left eye she's not abducting.
See that your
And the other thing
left
that's
eye
interesting to
just
note is that
not there at all.
her interpalpable aperture opens a little bit wider when she's really trying to get across to the left.
Struggling
So no
there.
issues looking up and to the right,
Normal there.
looking down and to the left. Sorry,
Down there.
you'll see it a bit better in a moment.
Can you lift up your eyelids for me, please?
So limitations,
Thank you.
no matter whether she's looking down or
Struggling
up
there.
or just straight across to the left.
Okay. So what
Now
I'm
there's
gonna get
one
you to do is
clinical feature
swing
that I just
from-
pause here for a moment. Sorry. So one clinical feature that I really want to emphasize here, and that is looking for abduction saccades. So the key thing is that when you're looking for abduction saccades, and it can be really subtle, you're trying to determine whether the abduction movement is symmetrical in speed and amount to the adduction of the other side. And sometimes it can be really subtle. And my suggestion is that you look at the bridge of the nose, because what you're trying to do is you're trying to get a sense of whether the two eyes are going across together, rather than one eye being slower and the other eye going across. So see if we can get to that part of the, beg your pardon. So have a look here.
There, so
Here she
it's going
goes.
up there.
So
Great. Okay. So what I'm going to get you to do is swing from
right, so
blinds.
she's looking left.
to the bookshelf.
Keep looking at the bridge of the
And back
nose.
to the blinds.
You get a sense that the left eye is lagging behind the right eye.
Perfect. Thank
Yep.
you.
So that's abduction saccades. And sometimes it can be really subtle, but it's such a helpful clinical sign to look for. Right. So this is gold. Right. This is, after this you can fall asleep. Right. This is what you want to take home. 6 nerve palsy, new onset, that needs an assessment, referral. Incomitant esotropia, there's an abduction deficit, and sometimes it can be really subtle, and a case later on will illustrate that point. But look for that secondary deviation, and look for the abduction saccades. Right, it can be quite subtle. Okay, I promise that we're going to see this slide again. So, you really want to start from, when we start from the front and go back, there's naturally, and you'll all be experts at this, I beg your pardon, no, that's fine. The second cranial nerve, the optic nerve, you'll all be very familiar with that, so I'm not going to go into that in much detail, but it is really useful to look at the optic nerves when you see somebody with the 6th cranial nerve, You won't always see papilledema, but if you see it, that's naturally a referral, an urgent referral. A reminder about the cavernous sinus anatomy. So the cavernous sinus has got, and just to orientate you, it's kind of a little between the eyes. That's high magnification view. And you can see the optic chiasm at the top and your pituitary gland. And on either side, you have a cavernous sinus that is filled with some really important structures on their way to the orbit, from the brain to the orbit. Your oculomotor nerves, 3, 4, and 6 are in there. Your internal carotid artery is in there, surrounded by, and your fifth nerve as well. So remember that your trigeminal nerve is divided into 3, V1, 2, 3, and there's a motor component. And V1 and 2 are in the cavernous sinus. And what's not depicted there, so I found this diagram, is that related to the internal carotid artery and your sixth nerve is the sympathetic plexus. So that's the reason why we're looking at things like, does somebody have a ptosis, and looking for anisocoria. So cranial nerves 3, 4, and your sympathetic nerve, you all know those signs. And the trigeminal nerve, your testing sensation, and the motor section, which doesn't come in the cavernous sinus, but it is related further back. And then when we look at, I'm going to show you a case now. So this is a 44-year-old lady, and she developed horizontal double vision quite suddenly, described it as more troublesome in the distance than near, and she had blurred vision, and she had a new onset headache that was quite significant. And she came to see the on-call registrar. No other neurological symptoms. She had some significant cardiovascular risk factors and was appropriately treated. This is Saturday night. She looks quite well, and vision not too bad. What examination findings are important, do you think? So some of the things that we just talked about. Yep, we'll definitely get there. She's got no ptosis, no anisocoria, and her ocular motility, interestingly, only shows an esophoria. But she's got symptoms, which we're not ignoring, because even though we've only found an esophoria, and interestingly, that her ocular motility seemed to be quite full and normal. So, because we're taking note of her symptoms, but we don't have any clinical signs, and we've done all these other things that are also important, she was told to come back the next day for a check. And as far as she's concerned, her symptoms are worse. They're now constant. And on examination, even the horizontal saccades was normal. And her optic discs probably were just a bit full. So the registrar said, well, come back again the next day, we'll do an OCT RNFL, because she was seen acutely where we don't have all these things available. But she rang that afternoon, headaches worse. So she came in and had an urgent CT scan, and a pituitary lesion was found. And at that stage, the differential was, well, is this a macroadenoma, or is this a meningioma? So she was referred onto the neurosurgical team, and an MRI scan was performed. So the next day she did come in, and her vision seemed to have, I don't think it really improved. I think it's just a different room having a test. But here her esotropia is starting to become more noticeable. So you can see that it's 10 prism diopters for near, 20 in the distance. On right gaze it's only 4, but on left gaze there's your 30. Okay. So you can see that it took some days for those signs to evolve, and she was found to have an isolated left sixth nerve palsy. Interestingly, her visual field was normal, because she landed up having this pituitary lesion. So here you can see, so that's a normal patient on the far side, and here you can see that there's a little bit of increased signal, which was a hemorrhage into her pituitary lesion. And there you can see the increased signal as well. So on the normal side, you can see that you can't see a pituitary gland that's not enlarged, but on this side you can see the lesion, and it's lining up. So here's just a case to illustrate that, I'm always listening to the patient, and just because you can't find the signs, you're almost more obliged to monitor them closely, because you don't know if something's going to evolve. So she'll end up having a very uncommon hemorrhage into her macroadenoma, which is an apoplexy, also known as Sheehan syndrome. And the neurosurgeons treated her, and eventually her sixth nerve palsy improved and resolved. So that was a lesion in the Petrix, in the blue zone, maybe a little in the green zone. I mean, it's kind of hard to know exactly where her sixth nerve was affected, but she had neuroimaging, which helped find the answer. Here's another case. Seems to be a bit dangerous being 40-something. So a year ago, she presented to her optometrist, and she presented with diplopia in left gaze, and she reported that sometimes she sees it in primary position. But her past history reflected that she had some issues in childhood. Her son had had strabismus surgery. She's a hypermetrope, and just a small amount of prism seemed to fix it. So that was dispensed. But she came back a year later, and she's now reporting that her diplopia is much worse, and she's now finding that she's having to close her left eye to be able to function. And that was the lady that adopted the face turn, the compensatory head posture. And her esotropia had certainly increased, which is a little bit unusual. I mean, you can see decompensation, but she couldn't abduct her left eye. And that was the video clip, the second one, that was her. So the clinical features, limitation in abduction, got it at a -3. Her esotropia is incomitant, and she had the secondary deviation. And fortunately, all the other clinical findings were negative, but just a reminder. So her esotropia is not particularly remarkable in primary position, but you can certainly see it there in abduction, whether she's looking straight across or up and left or down and left. And she has this incredibly rare lesion. So there's a normal MRI, and you can see there's just this massive lesion. And the value of gadolinium, the contrast, just helps to light up the lesion. A chordoma, so this is a transverse view of the MRI, and there's a coronal view. And there's a normal patient, you can see there's nothing in the big circle, there's a big lesion there. The chordoma is an incredibly rare bone tumor, and it's 1 in a million per year in the USA, and it's really challenging to treat. So she's seeing the neurosurgeons at the moment. So those are lesions that are kind of in that blue and green zone that we were looking at, the petrous part or the subarachnoid space. And naturally the subarachnoid space is also prone to changes in intracranial pressure, whether it's elevated. So we see that, and it's becoming more and more frequent. And even if your intracranial pressure is lower, so if you have a spinal tap, for example. But also remember that in this region, it can be unhelpful because it's not isolating exactly where the lesion is. So that's why they call it a false localizing sign, because the lesion can be anywhere, but it's affecting the sixth nerve secondarily. If you have a hemorrhage in the subarachnoid space, or if your meninges are affected in any way, whether it's infection, inflammation, infiltration, meningiomas are quite common, that can affect the sixth nerve. So going back to the slide, what we look for, what else you can do. I don't know if you're much in the habit of testing the other cranial nerves, and it's sometimes just a little bit of a habit. It's quite easy to do. I just rip off a corner of a tissue and I just do a gentle touch on the forehead and on the cheeks, and then you can test facial muscles very quickly. Ask patients to squeeze their eyes shut, puff up their cheeks, and see if you can just even press and see if they can hold it there. You can ask about their hearing, and don't forget when you're looking at their ocular motility to look for nystagmus. For example, if you have an internuclear ophthalmoplegia, you'll see abducting nystagmus, and of course convergence and accommodation. So where we're looking now is in the pons, the base of the pons, and the diagram up there will show you the sixth nerve, and it exits through the lower pons. It's related to the seventh nerve, so you can see the yellow nerve it curves around the abducens nucleus and exits the pons as well. And then this side-on view can also give you an illustration of why the eighth nerve for hearing is affected, if that region of the brain is affected. These parts of the brain are probably potentially parts that most of us want to run a mile when you start to hear about the medial longitudinal fasciculus and the paramedian pontine reticular formation, but they affect us because we would see them. And the MLF that's involved, then you'll get the adduction deficit on the same side and the abducting nystagmus. Or you might have a gaze palsy on the same side if the PPRF is affected. And sometimes you can have both, and that's when you have 1.5 syndrome. But you'll pick up that there's something abnormal with their ocular motility. And so here's a case where a lady had a 6th nerve palsy and possible INO, and she ended up having a pontine hemorrhage. And this is just mentioned for completeness sake, but there's some clever people that worked out that depending on what part of the pons is affected, you can have a combination of things, including, so the pyramidal tract is your motor control, and so you can have actually contralateral hemiparesis, but I don't think those patients will turn up at your practice, hopefully not. But anyway, it's just quite interesting the way these things were discovered. So this is a more typical case. You'll see a 70-year-old male presenting with sudden onset horizontal diplopia. And it's always really important to rule out symptoms of giant cell arteritis and other neurological symptoms like myasthenia gravis. And he's quite a character. He told me that he'd had 2 recent episodes of trauma. I nearly knocked myself out, but no double vision straight after. But you bear it in mind. Generally speaking, quite well. Maybe a few issues with his heart rhythm, but the ECG done that day was normal sinus rhythm, so he was referred on. And he had a left head turn, a small esotropia, which was worse on left gaze, so it's sounding like he's got a left 6. And his ocular motility was nearly full, so not much limitation, only a slightly reduced abduction. He had had a long-standing ptosis. He was the fellow that I showed you, the first video clip. And no other cranial nerves involved, and no Cogan's lid twitch, so no signs of myasthenia gravis. No suggestion of giant cell arteritis on his blood tests, and perhaps his cholesterol's a little elevated, but we concluded that he had a 6th nerve palsy, and the most likely was that he had a microvascular underlying cause. So we need to make sure that it is that, and that he's not getting any worse. So he came back for a review 7 weeks later, but he'd been pretty much wearing a patch the whole time, and he felt that probably he was worse. So as we noted, his signs were quite small in the beginning, and now you can see that the abduction deficit isn't mild anymore. You can see the esotropia. He was able to confirm that his ptosis was long-standing, and you can't see any anisocoria there, and you can see the abduction deficit. So we're now got somebody with a progressive 6th nerve palsy. So what do we do? And in that circumstance, probably it still is microvascular, but we can't be sure that there isn't another cause. So he had an MRI scan and an acetylcholine receptor antibody blood test, which is useful if it's positive, but not very helpful if it's negative. And they were both normal. So basically gave him the option of patching. Sometimes you can Botox the medial rectus on the affected side. And usually surgery is only considered if they don't get any better and if they're stable. So that's a conversation for much later down the track, because most of them, they improve. And he did. So 3 months later, everything had resolved. So what are the cardiovascular risk factors that we need to pay attention to? Well, it really depends on which study you look at, because Patel did a study, looked at 137 patients, found that hypertension was more of a concern than diabetes, but there are other studies listed below that found that diabetes was more of a concern, and maybe the combination. So I would pretty much say that, as on the left side of the slide, those issues we would tune into and go, yep, you've probably got cardiovascular risk factors. And makes your 6th nerve palsy most likely microvascular. So here's another case, 73-year-old with 3 days of horizontal diplopia. And he was interesting because he had headaches and normal vision, no other neurological symptoms. So what else would you like to ask him?
Is the diplopia worse distance sunlight?
Yep. And in relation to the headache? No GCA. Right, so it is something that we need to bear in mind, and I think I might have, some of you might remember that I've had the experience where the symptoms are so frustrating because headache can be anything, and loss of weight and fever and night sweats, they're so non-specific. And I remember a registrar that I worked with in Melbourne, and the lady that he was assessing was saying yes to everything, yes, 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 and then in exasperation he said, well, do you have itchy teeth? So his blood tests were normal. He did have some significant cardiovascular risk factors, was being on appropriate treatment, and we found the patient to have a sixth nerve palsy, no other cranial nerves involved, and diagnosed him to have a microvascular palsy. So should we scan him? We didn't, because we thought he had microvascular palsy. 10 days later, he presented again, feeling that things were worse, and particularly with pain, and the pain was bad. And so his abduction deficit had progressed, so should we scan him? And so we said, okay, let's do a check and make sure there's nothing else, and he still had an isolated sixth nerve palsy, no symptoms of GCA coming up, and all the blood tests were repeated and negative. And so the dilemma, do we scan him? Well, he still has nothing else to go on other than the sixth nerve, although his pain's getting worse. We thought, well, let's review him. We live in New Zealand, health resources are precious. So he came back, it's now Friday afternoon, it's been 12 days since he first presented, and he's now much worse, and his temporal pain's worse, it's now 9 out of 10. So we made a plan to still isolated, no other symptoms, and we still felt that he looked like a microvascular palsy, but we made a plan to arrange a scan, but of course it's Friday. So we arranged the plan for Monday, and I come to work on Monday, and Mahesh goes, do you still want him to have a CT scan? He had an MRI on the weekend. And I go, oh my God. And he presented to the emergency department on Friday night with the most excruciating headache, and then your heart skips many beats, because you kind of go, oh my God, I've missed a subarachnoid hemorrhage, and I'm sweating. And thankfully his MRI showed that all he had was some ischemic small vessel change, no subarachnoid hemorrhage, and that's where I'm really breathing a sigh of relief, because you're trying to make the best decision and you don't know until you look in hindsight, and thankfully he had no aneurysm. And this is his normal MRI scan. So, and that coronal section is looking through there, so we've missed the pons, which is the structure over here. And so he was diagnosed with sixth nerve palsy as microvascular etiology, and he just happened to have severe pain. And 2 months later, he started to improve, and by 4 months, everything had gotten better. So these cases, they stress you because you're making clinical judgments which could have significant consequences if you've missed something. And it's interesting to see that a study looked at how many patients have pain. So this is a study of 87 patients that looked at all the cranial nerve, well, oculomotor palsies, 3, 4, and 6, and found that half of them were sixth nerve, and half of them had pain. So pain's not necessarily a helpful feature, but it's hard to ignore. And somebody thought there might be a difference if you're diabetic or not, but there isn't. So, sixth nerve palsies, the dilemma is always which ones do you investigate? Which ones should have an MRI? Because it's a common problem, neuroophthalmically, and if one study of more than 4,000 cases looked at all of the oculomotor cranial nerves, just under 50% were cranial nerve 6, and 50% of them were microvascular. And it's this dilemma because it's not exactly a cost-effective way to MRI everybody. It's not always diagnostic either. But on the other hand, if you miss it, there are some grave diagnoses that you could miss. So we try to come to some conclusions as to who we should be investigating. And this is where honing in on your clinical skills and your clinical findings is so important. Because the point of this talk is not to make you fear a sixth nerve palsy and then you start referring everybody in. The point of this talk is to give you confidence to know what clinical signs are important and worrying so that you refer those patients in. And most of the time, you have time. You know, it's pretty reasonable if somebody turns up and you're not 100% sure that you bring them back for a review. So what's helpful is the presence of vasculopathic cardiovascular risk factors, their clinical presentation, so you know that sixth nerve palsies that you'd be worried about would be those that develop suddenly. They might have pain. Confidence in it just being an isolated palsy means that you've looked at other possible neurological features, and the clinical outcome you'll only know in hindsight after they've made an improvement. And the difficulty is that, so one study done by Chow with 66 patients with oculomotor nerve palsies, that in those that had a worrying CNS lesion, 56% of them had cardiovascular risk factors. So it's not really protective knowing that they do have it. And microvascular palsies can also progress, as you would expect a compressive lesion to cause progression in your sixth nerve palsy. And whilst microvascular patients, they do improve, by 6 months, more than 3/4 of patients have improved, and 86% of them might get complete resolution. There are still those that don't achieve complete recovery. And interestingly, that they might develop another oculomotor palsy sometime down the track. And that study was had an average of 6-year follow-up. So you can see the clinical dilemma, trying to decide who needs to have an MRI or not. But generally, as a rule of thumb, and I love this now that I'm in this age group, that if you're older than 50, you're old enough to have an MRI. But of course, if you're not 50, you should have an MRI. But if you're older than that, then you do want to rule out the other things, GCA, and it is reasonable to consider that your sixth nerve is related to a microvascular etiology if you've got cardiovascular risk factors, and refer to the GP for management of them. So here's a flow diagram which does help, and you can kind of think of it this way. I mean, the trauma patients will be obvious, and they're not likely to present to you. So naturally, if it's not isolated, and they've got other neurological features, they're going to need an MRI. It doesn't matter what age they are. If it's an isolated lesion, you're working out whether traumatic or congenital, and we're presuming that this is an adult that has congenital features, and they would likely give you a decent history. If they're vasculopathic, then you can observe them for a while, and if they've improved, then you don't need to do anything more. If they've progressed or they haven't improved, that's when you start looking to see whether you're going to refer them in so that we can investigate. And naturally, if they're not vasculopathic, then we'll have to investigate. So I think that's a helpful algorithm to guide us. And of course, there are other conditions that will cause abduction deficit. So particularly, even adults grow up. Adults that have Duane's as children, they grow up. And I recently did somebody that had cataracts and had a long-standing history of Duane syndrome. Thyroid issues, the orbital inflammatory disease, you'd expect to see some clinical signs. We talked about myasthenia gravis. The trauma patients, anybody that has a fracture in their orbit, which could be traumatic or iatrogenic. I thought it was worth talking about spasm of the neuroreflex because it's kind of always mentioned in passing, and it's probably something that you guys come across quite from time to time. And these patients have intermittent esotropia, and you would expect that at the time that they have the esotropia that they'll have pupillary miosis. And most of the time, so by far the majority of the patients don't have anything worrying. And it's worth knowing that there are some serious underlying causes, but by far the majority, if they're having those and they've got no other neurological signs, I think it's reasonable that you monitor them for a while. And of course, refer them in if you have any concerns about other features. So we've looked at the pathway of the sixth nerve, starting in the brainstem, going all the way through to the eye. There is a table if anybody's interested, but it really just looks at each location and the possible causes, and that's more for interest. But I remind you that this is the take-home message. This is what hopefully will give you confidence to know that you've assessed your patients, and these are the ones that you need to refer in. Anybody that's got the incomitant esotropia, they've got an abduction deficit, it might be quite subtle, and look for that secondary deviation, and look for the slowing of the abduction saccades, because those are all very helpful clinical signs. Thank you for your attention. Does anybody have questions?
Can you do anything for the pain?
We would probably just address it as first principles, whatever oral analgesia. But often we'd be leaning on the GPs to provide some support there. But it can be tricky. I think they do respond to some usual painkillers.
Can they go on ACC or something if they're off work and they've got double vision for 2 or 3 minutes, or is there not really any support?
Only if it's been trauma related. So the microvascular palsies, or like this poor lady that's got the chordoma, she's not ACC. Yeah, it's got to be trauma related. Yeah. Anybody else?
Would you be looking to treat the symptoms of diplopia during the period where they're going to be hopefully...
Very much so. So this lady that has the chordoma, and she's quite symptomatic, she's got a Fresnel prism on her glasses. And she's just going through the workup and the assessment by the neurosurgeons to determine what definitive management she's going to have for the chordoma. And yes, so I've said to her, you're going to need this Fresnel prism. I don't know if the prescription's going to change. We can change it. And later down the track, when she's gotten through all of this other stuff, then we'll reassess her. And I'm only going to consider surgery if it's necessary, because I don't know if she'll improve. She might find that having prism into her, ground into her spectacles is a reasonable solution, because they're quite tricky to get to do strabismus surgery. I wouldn't be surprised if they still land up needing to have some prism anyway. So if she had a large amount of esotropia, then we might have to do something, but it's going to be tricky, because if she's got no movement on her left lateral rectus, then I'll be scratching my head to find a solution for her. But not uncommonly, prism ultimately is still needed.
What kind of value prism might you end up suggesting?
In terms of temporary,
Yeah.
or when before I start to, as a rule of thumb, generally about 15 prism diopters of esotropia or greater, I'd be starting to think about a surgical solution. But I have some patients who, I've got one fella who's very conservative, not keen on having prism at all. He's more a long-standing esotropia, and so he's got the maximum prescription of prism in his glasses, plus a stick-on Fresnel, and he says, I'm fine with this, I don't want surgery. And I have operated on somebody that's had 10 prism diopters, who's bitterly complaining, younger fellow who really wanted to function normally, and we went through the whole thing of, well, you're not bad enough to actually, we don't usually, but we do sometimes, and he was the sometimes, and he was very pleased. So just moving that medial rectus a little bit, recessing it just to reduce his degree of esotropia, has given him a huge functional improvement. So there's always, you know, the guidelines and then the outside on either side. But yeah, I mean, and even occlusion, you know, that for some patients that's all they can cope with. Because the Fresnel prism is quite tricky for some people. Sometimes it's quite tricky because those grid lines, they do create this prismatic effect and they get a spectral of colors, and some people can't tolerate the blur, and so it might alleviate the double vision, but they just can't function like that. So sometimes for some patients who fail the trial of the Fresnel because they can't tolerate the blur, sometimes have to have the prism ground into their glasses, and we just go, well, you know, you might have to have the prism updated, and yes, there's a cost to it, but you know, they couldn't get through the trial of Fresnel. Yeah, I'm sure you've all come across those cases.
In terms of the magnitude of the prism, would you normally determine that based on the deviation in primary position, even if they've got a compensatory head posture?
So if it's acute onset, then I would try to neutralize their head position, because they're only adjusting their head position to compensate for the deviation. So I would usually test them in primary position and get rid of their compensatory head posture. For patients that are not 6 nerve palsy, that have had long standing, they might just be habitually in this head posture. And no matter, I mean, it's a really important question to raise, because when you're doing the cover test, you do want to make sure that you try and get them in a head posture to take away that compensatory head posture. But you'll find that there's a group of patients who are just habitually in that, and they just keep drifting over. And sometimes then I kind of go, well, actually, if this is your preferred head position and we're not going to undo the wiring to get your head neutral, then maybe we'll just take the measurement when you're in your compensated head posture. Yeah. Anybody else?
In terms of driving and things with these patients, obviously if they've got an acute onset, you know, that need to be taken a period off driving anyway. But if you've got someone who's got, you know, reasonably long-standing, you know, palsy, and they can get single vision in primary gaze, but obviously in their peripheral gazes and things like that, it's not so good. What are your sort of views on driving in terms of that sort of deviation?
So the law is very grey in this area, and I think that it also depends on the patient. And the younger the patient, the more likely they are to be able to manage. Because, you know, for example, a 4th nerve palsy, they're definitely incompetent. You know, they're going to be different depending on where they're looking. Patients do tend to intuitively adapt quite well. So instead of looking to the sides, they tend to find that they can move their heads. So I do try to gauge it and have a conversation with the patient and try and sense how much common sense they have. Most patients do have enough common sense where they recognize, actually, I can't do this, or yeah, I can cope and I've adapted well. So I think it's just a matter of giving them guidelines. I mean, and it's one of the worst parts of our job, isn't it, to tell somebody that they can't drive anymore. You know, it's really hinders somebody's independence. So I do try to be mindful, but then we've also got that balance to strike with protecting the public. I do say to people, if they're struggling and they suddenly have double vision, that immediately, just to figure out what is the real object, is to just shut one eye, because that'll get them through that immediate. Because I mean, I have a couple of patients where their double vision is intermittent and then might just come on at the most inopportune time whilst they're driving, and then they're suddenly, you know, so to just give them strategies for dealing with it. But yeah, it is a bit of a common sense, have a conversation with them. I haven't actually ever been in a position where I've had to, or maybe just once, threatened to write to land transport to say, you need to take this driver's license off somebody. So fortunately, most people recognise. Yeah. Anybody else? Super. Well, I'll hang around, and we could even move the chairs if you want to stay and have a drink, if there's any little bit of food, because it might be a nice time for you to catch up with your colleagues as well. But thank you everybody for coming. It's really nice to see you all.